So I would like
Thank
to
you.
present our second speaker for today, Dr. Ahmed Hassanin, Assistant Professor of Anesthesia and Critical Care Medicine in Cairo University. Dr. Hassanin is also certified consultant of anesthesia and critical care medicine in Saudi Arabia and Kuwait. In addition to that, he's a holder of the European Diploma of Anesthesia and Intensive Care Medicine. He practiced anesthesia and intensive care medicine in 5 countries. And I presume different continents as well. Dr. Hassanin has 55 international publications and also reviewer for multiple international journals. His main research interest is critical care and hemodynamic monitoring. Dr. Hassanin will talk to us today about monitoring of tissue perfusion in shock. And without any further ado, I would like to give the microphone to Dr. Hassanin.
Thank you, and Assalamu alaikum wa rahmatullah.
Alaikum.
I will talk about monitoring of tissue perfusion in shock. I will start by revising the of septic shock according to their last definition on JAMA on 2016. The sepsis 3 definition was hypotension requiring vasopressor therapy to maintain mean blood pressure at 65 and having a serum lactate greater than 2 after adequate fluid resuscitation. So we have 3 components should be present to say that this patient is in shock. Hypotension, serum lactate is elevated after fluid resuscitation. If we have an example for this case, a patient presented to the ER with this surgical abdomen, the mean blood pressure was 45, capillary refill time 8 seconds, lactate 0.5. Is this patient in septic shock? The answer is we have now 2 components, impaired perfusion and mean blood pressure 45. If we give this patient 1.5 milliliters crystalloids and the mean blood pressure became 65, case B is the same case. Mean blood pressure is low, capillary refill time is 10, lactate is elevated. Is this patient in septic shock? The answer is maybe. Why I said maybe? Because we have now 2 components, not 3. We have low blood pressure and we have elevated lactate, but we didn't examine the response to fluids. If this patient received 1.5 liters and the mean blood pressure became 65, so this patient is not in septic because we didn't fulfill the 3 components of the definition. Case C is the same patient, mean blood pressure 45, capillary refill time 10 seconds, lactate 3.5, received crystalloids, but the mean blood pressure is still low, and we needed norepinephrine to initiate to maintain the blood pressure. Is this patient in septic shock? The answer is yes. Why? Because we fulfilled the 3 components of the definition: hypotension requiring vasopressor therapy, serum lactate greater than 2 after adequate fluid resuscitation. The surviving sepsis campaign bundle, which was developed in 2018, developed an 1-hour bundle. It contained many components: measure lactate level, obtain blood cultures, administer broad spectrum antibiotics, and administer 30 milliliters per kg crystalloid, although this component was removed in the 2020 guidelines, and apply vasopressors. When we observe these recommendations, we will find that measuring the lactate level is the first step to define shock. So if the previous patient in the OR had mean blood pressure 65, capillary refill time increased to be 12 seconds, lactate increased to 4.5. Although we have a normal mean blood pressure or accepted mean blood pressure now, we should increase the norepinephrine dose because we have impaired peripheral perfusion. Post-operatively, if this patient had a gangrenous colon and did resection anastomosis and was admitted to the ICU with mean blood pressure 65, capillary refill time decreased to be 6 seconds, the lactate decreased from 4.5 to 3, and we are on or norepinephrine infusion. What is the next step? The next step is to take your coffee. Why I said this? Because when the peripheral perfusion improves, when the capillary refill time improves and the lactate improves, you are doing the right management, and now you can have a rest. The message from the previous story is impaired tissue perfusion is the cornerstone in definition of septic shock. What about other types of shock? Is septic shock only the one which need elevated lactate to be defined? No. In this review article by John Weavenso and Daniel Dubaquero, where the vice presidents of the European Society of Intensive Care, it was published in New England Journal of Medicine. When they define circulatory shock, the first step is there hypotension or no. After this, the second step, signs of tissue hypoperfusion. If the sign of tissue hypoperfusion is absent, so this is not shock. This is chronic hypotension or syncope. If there is hypoperfusion, so this is a circulatory shock, and you can go further to manage this patient. What are the basic steps of management of shock? As we said, the 1 hour bundle is the first step, initial resuscitation, then echocardiography to determine the cardiac output, then determine the fluid responsiveness to see whether your patient will need fluids or not, and the last and the important step is to determine perfusion indices. This is the importance of our subject today. What are the physiological consequences of fluid administration? When we give a patient fluids, the mean systemic film pressure increase, cardiac output increase, and mean blood pressure. Then the microcirculation will have increased flow. Then there will be oxygen availability to the tissues. Then there will be aerobic metabolism and organ function. These are the steps from starting fluid administration till reaching organ function. When there is shock, one of these steps is disturbed. For example, if we have capillary leak or vasodilation, the mean systemic film pressure will decrease. If we have hypovolemic shock or preload unresponsiveness, the cardiac output and the mean blood pressure will decrease. If we have microcirculatory dysfunction or edema or hemodilution, this means that we have an impairment of tissue perfusion. Then we have the last step is mitochondrial dysfunction. It will affect the oxygen availability and the aerobic metabolism. If we tested the circle, preload responsiveness and the fluid responsiveness, we will determine one stage of the shock. And if we determine this circle, this will be the main core of our topic today, which is peripheral perfusion. Peripheral perfusion, we need to evaluate one of these 4 steps. Organ function is the first one, aerobic metabolism is the second one, oxygen availability is the third one, microcirculatory flow is the 4th one. So perfusion indices will evaluate one of these 4 steps. How will we evaluate organ function? Through clinical evaluation of organ function. How will we evaluate aerobic metabolism? Through markers of aerobic metabolism. How will we evaluate oxygen availability? Through markers of oxygen delivery. How will we evaluate microcirculatory flow? Through markers of peripheral perfusion. I will take the first step, which is clinical evaluation of organ function. A clinical evaluation of organ function, such as CNS, if the patient is disoriented or drowsy, this will denote that there is impaired perfusion. If we have the diminished urine output, this may denote that we have impaired perfusion. But is oliguria a good perfusion index? The kidney receives 25% of the cardiac output and extracts a low amount. Thus, it can tolerate cold ischemia. Renal blood flow is preserved and even increased in septic shock. Acute kidney injury in septic shock is mainly due intrarenal microcirculatory abnormalities and not due to global hypoperfusion. Oliguria is a non-specific symptom which can be present in mild dehydration endocrine pathology after surgery. So the answer of this question is oliguria a good perfusion index? No, we should not rely on oliguria to say that our patient is perfused or not perfused. The second step is markers of aerobic metabolism. The most famous marker is serum lactate. Serum lactate is the gold standard of definition of shock. In this study in critical care medicine, they found that serum lactate is associated with mortality in severe sepsis. If we look about at this result, we will found that the lower lactate level has lower mortality and the higher lactate level has higher mortality. And in this figure, we will see that whenever the lactate increases, there is increased mortality. Not only the lactate, but also the change in lactate with resuscitation. In this study, they evaluated the change in lactate after cardiac arrest, and they found that in the in the survivors, the lactate decreased more than the non-survivors. So if I followed my patient and found that lactate is decreasing, this will tell me that my patient is better. Their conclusion was that lactate clearance is predictive of overall mortality rate in critically ill patients. Now the question, is serum lactate the ideal measure of tissue perfusion? This was answered in this review article by Jan Bakker, which is a famous scientist in peripheral perfusion. He is from Netherlands. They found that they put this algorithm which starts with elevated lactate. If we looked at this algorithm, we found the first step after finding an elevated lactate is to see possible cause of increased lactate other than sepsis, which means that we have other causes of increased lactate such as seizures, liver ischemia, diabetic ketoacidosis, some medications. All these causes can increase lactate and can deceive us and give us a false impression that the patient has shock. So in this study, the same scientist, Jan Bakker, and another famous one is Glenn Hernandez, in Annals of Intensive Care, they found that after 24 hours of admission, the serum lactate remained elevated in 50% in patients who survived. So after 24 hours, if I found the lactate is elevated, this doesn't mean that my patient will die. 50%, as shown in the figure at the right, 50% of the patients after 24 hours have elevated lactate and will not die. In the same study, the scientists found that other perfusion indices such as capillary refill time and CO2 gap were normalized within 6 hours in surviving patients. So the answer of our question, is serum lactate the ideal measure of tissue perfusion? The answer is serum lactate still now is the standard perfusion index. However, it has the following limitations. Number one, it can be elevated in conditions other than shock. It is slowly normalized, and its follow-up requires frequent blood sampling. This should be taken in consideration. When I have a measure which needs frequent blood sampling, this is invasive and this is expensive to my patient, especially if we are talking in resource-limited settings. Now, after the markers of aerobic metabolism, which is lactate, the markers of oxygen delivery, global and local. I will talk in the first about global markers of oxygen delivery. Oxygen delivery has three components, as all of us know, hemoglobin and saturation and cardiac output. These are the three major determinants of oxygen delivery. These determinants lead to oxygen delivery to the tissues, and the tissues use oxygen and produce CO2 and some oxygen return back in the venous blood, which is the oxygen saturation. So I have at the end venous oxygen saturation and venous CO2. If I took the venous oxygen saturation and talk about it as a perfusion index, I will have an explanation of this with if I have an agricultural land and I have a canal which deliver water to the land, and another canal which takes the waste from the land. If I found that the drain or the waste is too much, this will denote that the land is well perfused. But if I found that the draining canal is empty, this means that the land is very thirst because it took all the water and didn't leave anything. The same will be applied to the venous oxygen saturation. If I found the oxygen saturation in the venous blood too low, this means that the tissues took most of the oxygen which was delivered by the artery. But if I found that the oxygen saturation in the venous blood is high, this will mean that the tissue did not take all of the oxygen. This means that the tissues are relatively well perfused. Now I finish the oxygen, the central venous saturation, I will talk about the CO2, the venous CO2 gap. What is the venous CO2 gap? It has another story to describe its importance. If I went to a metro station and I found that the metro is empty and the station is empty, this means that the metros come every 5 or 6 minutes. But if I found that the station and the train is full of passengers, this means that the train come every 1 or 2 hours. I mean that when the frequency of the trains are higher, the passengers will be drained and I will find less amount of passengers in the station and in the train. The same could be applied on the CO2 in tissues. When the tissue produces CO2, it should be drained by the blood flow. If I have stagnation in blood flow due to shock or respiratory or circulatory failure, this will lead to stagnation of CO2 in the tissue and increased CO2 in the venous blood. This will widen the gap between the venous CO2 and the arterial CO2. The gap between the venous and the arterial CO2 is normally less than 6 millimeters mercury. If it was increased above 6 millimeters mercury, this can denote that the patient is hypoperfused. And this was proved in the following study. This study by John Whittle and other colleagues, they took 10 patients with cardiogenic shock and delivered dobutamine infusion and measured the cardiac index and the CO2 gap. They found that whenever the dobutamine dose increased and the cardiac output increased, as in the left figure, the CO2 gap decreased as in the right figure. So if there is correlation between the CO2 gap and the cardiac output. About the central and the mixed venous saturation, in this study at critical care 2006 and 6, we will find that in the patients of complication with intra or post-operative surgical complication, the lower central venous saturation is associated with complications, the higher central venous saturation. And the conclusion was that the post-operative complications are more in the patients with low venous oxygen saturation. Our question now, are the CO2 gap and the central venous saturation the ideal measures of tissue perfusion? The answer is both measures are good indicators for perfusion. However, they have these limitations. They need frequent blood sampling. If I want to measure the CO2 gap, I should take arterial and venous samples at the same time, and this is expensive and invasive and cannot be repeated every now and then because this is too much. This will lead to too much cost. Also, the high central venous saturation does not exclude shock. So till now, we didn't reach the ideal measure for peripheral perfusion, although all these measures are useful and they can be combined together. I finished the global markers of oxygen delivery. We have local markers of oxygen delivery in certain organs, such as the renin. All of us know that the renin and angiotensin is the axis, one of the axes that control blood pressure. When the blood pressure decreases, the kidney perfusion decreases and the kidney produces renin to increase the level of angiotensin and make vasoconstriction to elevate the blood pressure. So if I found the renin elevated in a patient, this means that his kidney is not well perfused. And this was proved the last year in a study in critical care medicine. They compared the lactate and the renin and found that renin was more accurate than lactate in following up the patient. But this is one study. It was not replicated yet in other studies, and renin is not really available in the market for measure. It is only used for research purpose. But in the next few years, if it proves that it was proved that it is better than lactate, we may use it in our clinical practice. Other measures of oxygen delivery are present, such as near infrared spectroscopy and such as transcutaneous pressure of oxygen, but these measures need expensive devices and are not readily available in our country. The last part of our lecture is the markers of perfusion, peripheral perfusion in non-vital organs. Why I say non-vital organs? Non-vital organs deteriorate earlier and it recovers later than vital organs in circulatory failure. In other words, the shocked body would sacrifice the skin and the skeletal muscles first before sacrificing more vital organs such as the heart and the brain. So when I found that the skin is cold and there is mottling and there is delayed capillary refill, this may be present in a shocked patient before hypotension and before elevation of lactate. In this study or this case report in New England Journal of Medicine, this is a patient of cardiogenic shock. In the left side, you will see that the skin is mottled, and after 24 hours of resuscitation, the skin returned back to the normal color. So skin mottling is a very clear sign of hypoperfusion. In this study, a French group found that a mottling score can predict the survival in septic shock. They made the score according to the area which is mottled in the skin, and they found that if the score was low, this will have good survival. When the score increases, there will be a rapid death than when there is no mottling. They found also that increased mottling is associated with lower urine output, higher lactate, and higher SOFA score. The same group found that the decreased skin perfusion using the laser Doppler, and another group used the thermal camera and found that the mottling score reflects the perfusion of the skin. The second peripheral perfusion index, which I will talk about after the mottling score, is the capillary refill time. Capillary refill time is simply done by firm pressure on the distal phalanx for 5 seconds and recording the time to return the normal color. The upper limit of normality is 2 to 3 seconds. The same French group which studies the mottling score did this study where they found that when they compared the survivors and the non-survivors in shocked patients, in septic shock patients, they found that the capillary refill time is higher in the non-survivors. It is 5.6 seconds, while it is 2.3 seconds in the survival at the index and the knee also. It can be done at the index and the knee. They found also that the survivors has lower capillary fill time after 6 hours compared to the non-survivors. Another measure is the perfusion index, which is measured by the pulse oximeter. It is the ratio between the pulsatile and the non-pulsatile portion of peripheral circulation. When there is vasodilatation, the pulsatile portion will increase and the perfusion index will increase. When there is vasoconstriction, which is a state in shock, the perfusion index will decrease because of peripheral vasoconstriction. In this study, the perfusion index was measured in patients in critically ill patients, and they found that the survive when there is impaired perfusion in T1, the perfusion index was that means that the lower perfusion index. In this study, it was performed in our university, in Cairo University, and I was one of the authors of this study. We evaluated the perfusion index in patients with septic shock, and we found that if the perfusion index was less than 0.3, it predicted that this patient will need vasopressors. And if the perfusion index was less than 0.2, this predicts mortality. This was published in Shock in 2015. Now the question, is perfusion index an ideal measure for tissue perfusion? The answer is Perfusion index is non-invasive, useful measure, and give a continuous reading. And it is a real-time measure, which is an advantage over all the previous measures. However, its main drawback is the wide variability of the baseline values. We don't know what is the normal perfusion index. One person may have perfusion index of 5, and another person can have a perfusion index of 3 or 2, and both are normal. So it is better to be used for follow-up. Now we will move to the temperature gradient. This study was published in Circulation in 1969. They measured the temperature of the two in shocked patients, and they found that when the cardiac index increased and the mean blood pressure increased, the two temperature increased and the lactate decreased. They also found that when any of these variables is reversed, all the other variables will be reversed in the same direction. When they did correlation between temperature and cardiac index, they found that there is a positive correlation between both variables, and they also derived an equation to calculate the cardiac index from the two temperature. Also, they found that the lower two temperature is accompanied with this. More recently, other temperature measures were used, such as the forearm to fingertip skin temperature and the central to two temperature difference. Both measures are more accurate than the single reading of the two temperature because they will not be affected by the ambient room temperature. This is another measure which is room temperature. When the gradient between the two temperature and the ambient room temperature increase, this can predict poor prognosis. So if I finish now the peripheral perfusion indices, which are the mottling and the temperature gradient and the perfusion index and the capillary refill time. Now we have metabolic indices and the peripheral perfusion indices. Which is better? This was answered in this review by the same group which done most of the previous studies. They found that the traditional markers of tissue perfusion may not be readily available, such as the lactate, and may take time to assess, such as the urine output, while the skin is easily accessible organs and can be evaluated more frequently, and it is more economic and earlier to be discovered than other measures. Why are the peripheral perfusion indices better than the global indices? In this famous study, which is one of the most important studies which will change the practice of medicine, it is called Andromeda Shock Randomized Trial. It was published in JAMA last year. They found that they compared the lactate guided therapy and the capillary refill time guided therapy, and the first analysis found that no difference. So if you use capillary refill to guide the therapy of your patient, it will not be worse than using serum lactate. The results of this study were then reanalyzed and published in the American Journal of Critical Care Medicine, and they found that peripheral perfusion targeted resuscitation, I mean the capillary refill time, resulted in lower mortality and faster resolution of organ dysfunction when compared to lactate targeted resuscitation strategy. The same study was reanalyzed and published in Intensive Care Medicine as a letter, and they found that the capillary refill time not only improves the outcome, but also it can detect the phenotype of the shock. If the capillary refill time was normal, even if the lactate is high, this means that this shock is not severe and this patient have a high rate of survival. Also, the capillary refill time has the advantage of detecting what is called hemodynamic coherence. In this review article, this is a diagram describing what is meant by hemodynamic coherence. Preserved hemodynamic coherence means that there is a coherence between the macro circulation, which is blood pressure, and the macro circulation variables, and the micro circulations at the tissue level. If I don't have this coherence, I will give fluids and there will be a capillary leak. So there will be a dissociation between the macro circulation and the micro circulation. I will improve the blood pressure and the feeling pressures of the patient, but this will not improve the peripheral perfusion. The capillary fill time has the advantage of detecting the hemodynamic coherence, and it has rapid kinetics and correlated with deep hypoperfusion markers. Also, capillary fill time can it is associated with deep hypoperfusion markers. Why are the peripheral indices better than global indices? The capillary fill time is more dynamic than the serum lactate, so it can be followed up at shorter intervals. As I said previously, the serum lactate may remain elevated for 24 hours in 50% of the patients. The capillary fill time can detect hemodynamic coherence. The capillary fill time also can identify the shock phenotype. And finally, the capillary fill time is simple, economic, repeatable, and non-invasive. Now, if we revise the basic steps of management of shock, we will find that our steps are initial resuscitation, echocardiography, fluid responsiveness, and perfusion indices. Don't forget, when you revise the perfusion indices, you should revise the patient for the adverse effect of fluid resuscitation. You should maintain the perfusion of your tissues, and you should also confirm that the fluids will not harm your patient. What are the adverse effects? Lung congestion, hemodilution and coagulopathy, right ventricular dysfunction, and increased intra-abdominal pressure. All these signs should be clearly, closely monitored when we are resuscitating our patients. So if I have fluid infusion, I need to see whether my fluid infusion is effective or not through the oxygenation indices and the cardiac output and the preload indices. And I will need also to see whether my fluid exerted adverse effects or no, such as lung edema, hemodilution, right ventricular dysfunction, and intra-abdominal pressure. This review article was published by our group, and it summarized all the perfusion indices. It will be a very useful reference, and I summarized in it all the perfusion indices, and everyone with its advantage and disadvantage. I hope it will be helpful for everyone to revise all the previous data. The summary is poor perfusion equals shock. I will never say this patient is shocked except if I have poor perfusion. Persistent poor perfusion equal poor outcomes. Perfusion indices include anaerobic metabolism indices such as lactate, or indices for oxygen delivery such as central venous saturation, and peripheral perfusion to non-vital organs such as temperature gradients, skin mottling, and capillary refill. And these are the best perfusion indices. Lactate is still the gold standard. However, it has important limitations. I already discussed it. Every measure has pros and cons. So it is essential for every anesthesiologist and critical care physician to know all the indices and the limitation of everyone, to choose according to the situation and the resources in the hospital. The capillary refill time is a simple measure for perfusion indices, and it has many other benefits such as detecting hemodynamic incoherence. And finally, don't forget to monitor the adverse effects of fluids such as lung edema, oxygenation, intra-abdominal pressure increase, and hemodilution. And thank you.
Thank you very much for this lovely lecture, Dr. Hassanein.
Thank you.
I've got some questions. The first one: does sudden acute drop in end-tidal CO2 is good indicator for lung hypoperfusion without any change in ventilatory settings?
Yes, the answer is yes. CO2, if the end-tidal CO2 was decreased, this may denote that the cardiac output is decreased, but we should confirm that there is no ventilatory problem or chest problem. And in my practice, when I see an end-tidal CO2 suddenly became 25 or 20, I usually predict that the following blood pressure reading will be low. This is right.
Brilliant. Regarding renin and its use to diagnose hyperperfusion, is a daily level satisfactory, or do we have to do it more often?
Till now, the serum renin is under investigation. There is only 1 or 2 studies on it, so its use was not yet implemented. Even the normal values are not known. We are going to see, there is an ongoing thesis in our university. We are examining renin in septic shock patients, but we still didn't have results yet. So I can't answer this question. This question, I think, will be answered in the next few years when more studies evaluate this marker.
Okay. We've got 2 questions. I think they're both the same regarding the capillary fill time, because it is very subjective to measure. So what do you think is the best way to measure it?
Yes, I agree with this question. The problem with capillary refill was previously said that if I pressed on the capillary refill time, my pressure will be different than your pressure, than another one pressure of the male will be different than the female. And they, in some studies, but I didn't go further in these studies because the time is limited, they invented a device which make a standard pressure so that to compare, to be able to compare patients with each other. But this is not, we like the capillary fill time because it's simple. If it was, some scientists invented a device to measure the capillary fill time, to make a pressure standard pressure. But this device will be complicated and will make the measurement not feasible in every hospital. So there is another assumption which is making a firm pressure with your finger as a doctor till your finger is white. If your nail became white, this means that there is no perfusion in the finger of the patient. And then you release your finger and count the seconds by a stopwatch. It is very simple. The problem was in how much pressure should I apply. But measuring the refill time is not so difficult, especially when we know that the lower limit is 2 to 3 seconds. So any number above this number, 5, 6, 7, 8, 10, 12, it will be prolonged. It is not necessary to know exactly what is the number.
Okay. Also, we have another question. What is more dependent for perfusion indices, lactate or capillary fill time or mean blood pressure? I think we've answered that during the presentation. Is that the capillary fill time is kind of more
is the best. The serum lactate is still the standard in the definition and in the guidelines. But I think that the capillary refill will be introduced recently because the large study of JAMA is published last year. So its consequences are not yet implemented in the guidelines. The mean blood pressure should never be used as perfusion index because the mean blood pressure, the normal differs between persons and each other. And I don't know whether this blood pressure is sufficient to the patient or not.
Okay. And lastly, it is not regarding hemodynamic monitoring, but I think it is very common questions. Question is the role of corticosteroids in septic shock.
According to the guidelines, hydrocortisone 200 milligrams per day divided on 3 or 4 doses are recommended in any septic shock patient if he was on vasopressors. This is the last evidence till now.
Yes, I have to say that I did my my master degree back in 2000 and 2009, and that was my essay question, and it's still the same, still no change since then. Still, again, for septic shock, unresponsive to vasopressors. Yes.
Now it was changed. In the 2012 guidelines, it was recommended if there is if the patient is not responding to those vasopressors. Now it is recommended in any patient on vasopressors.
Vasopressors, yes.
Any patient, even if it's stable on vasopressor.
Brilliant. Any further questions? Any more questions? That's it. Brilliant. Actually, I've got a question, which is something. Last year, I attended kind of workshop about artificial intelligence and the implementation of technology in healthcare. And there was a device. The company was promoting it, and it was about actually detecting blood pressure or hypertension intraoperatively, even before the patient blood pressure starts to drop. So about 10 minutes before the blood pressure starts to drop. And they looked at very various and multiple things in terms of some hemodynamic measurements or indices, and they looked at different things in terms of the monitor itself, blood pressure, heart rate, and they also analyzed the ECG, a lot of things. And they actually, using a lot of data, they could predict the hypertension 10 minutes before it happens. So I think in the future we might have something like that in the context of critical care and shock patient, where like they use a lot of indices and a lot of data to inform us about whether this patient will be responsive to vasopressors or whether they'll be responsive to fluids and how much and stuff like that. So maybe in 10 years time, it's going to be all done by a computer. All right, I would like to thank Professor Khalid and Dr. Sani for the lovely night tonight, and I hope that was useful for you all. It was useful for me, and I enjoyed it very much. I would like to thank the Mega Academy team and Dr. Sad specifically for his effort and dedication. I hope that it was a lovely night for you, all of you. Thank you very much.
Thank you. Thank you.
Thank you very much. Okay.
Thank you.
Thank you very much, everybody. Thank you very much, Prof. Khalid and Prof. Ahmed Hassanin. And a special thanks for Dr. Reedy. He's dedicating his time for moderating this session. And thanks for all our guests and Dr. Anna from Canada, Dr. Adil from Emirates, and other people from Egypt, Dr. Sahar Marzouk, and my colleague, Mega Organizer. A special thanks to Dr. Walid Aswa and Dr. Hisham Abdul Maqsood. Everybody is so proud by the structure and the function and success of the Mega online course. 2 excellent lectures tonight. I'm so proud. Couldn't be more proud than tonight. Thank you very much.
Thank you very much. Thank you.